Welcome to the main room. We encourage you to have cameras if you can and audio. We'll give others a few more minutes to join on. Welcome, everyone. We'll get started here in a couple of minutes. All right, as folks continue to join us, we will do a roll call in the chat. So we will do name, pronouns, where you're calling from, and your organization. And we'll just be able to see who's joining us from where. Bonus question, how many inches of snow, if you saw them this week? It's really bright in my office and I don't have a single light on. It's all from 4.5 inches of snow outside. I'm not used to it. I'm on the non-sunny side usually, and it's very bright here, so. Yeah, we got about 4.5 inches and we are gearing up for round 2 starting again tonight. So we'll see how this weekend goes. Yes, and very cold. We will have a high of -10 on Sunday. We're just really in it this week in the middle of the country. So I'm not quite sure how we're going to take our dog out carefully in that. She's a little French bulldog, so she's extra sensitive to that. So we'll see how it works this weekend. No. Awesome. We'll continue to plug into the chat. We're going to kind of do some primer questions. I thought that would be good before we kind of hand over to our faculty, but today's kind of informal. We just want you to be on video and audio, and we just want to talk about what you're working on, what TA needs you have, what evaluation or data sets that you've all got your hands on. So I'll do a couple primer questions that'll be helpful as we reference back to the chat, but I believe all but Bill is on just yet, but we should have him on here shortly. But I'm going to drop in a couple questions. So what data set did you use most recently? So today, yesterday, last week. What project have you spent the most time on since we met in June? Will you be involved in the upcoming needs assessment for your community? And then what is one skill / analysis that you are still hoping to strengthen following the course? So I'll add these to the chat. Just to kind of help us think about what would be most helpful from faculty, what you're working on, things like that. Oh, and I just sent that too. There we go. Right. So feel free to respond in the chat. We'll kind of have that as notes as we talk and chat today and discuss everything that's going on, but I'll kind of hand it over to the faculty for the roundtable.
So, I mean, kind of the idea is we can talk about those things. We can talk about, data sources, data analysis stuff. But I mean, we can also talk about career stuff and it's not like it's a thing where, you're here to ask the faculty questions and get it answer each other's questions, right? Share your career experiences and things like that too. So, I mean, I think that's the hope, is just that we kind of have an open discussion about what you want to talk about, right? I mean, if you want to talk about, pros and cons of going back to grad school, or, if you want to work at the, I don't know, if you want to change jobs and maybe you want to work at the federal level and you have questions for Catherine about that, or whatever. So I think that we're pretty open to whatever folks want to talk about, and putting things in the chat is good.
And let's give a shout out to Aaron.
Yeah. So can you tell us a little bit, Aaron, about what you're doing?
Oh, sure. Sure. So I was working, as you might or might not remember, for one of the tribal epicenters. And they needed someone to go to City Match, and I was delighted to be chosen. Directly after both of my bosses resigned, I was feeling a little at a loss, and the Montana had an opening for a maternal child epidemiologist supervisor. So the City Match training really, really helped. And I'm just so happy, and thank you so much.
That's awesome. Congratulations.
That's very cool. That's
Thanks.
great.
Yeah. So what type of work are you doing?
So I'm not doing as much analysis as I'd like right now. I'm still trying to learn program management. I'm mentoring 2 other EPIs and 2 data analysts and a GIS person. So it's a lot of all of a sudden supervisory duties that I wasn't expecting, but I'm really happy to have this job. So I'm going to learn.
And how is that transition going, right? I mean, like, that's kind of a big deal going, if you're going from the person who is doing the stuff and you're getting recognition for, doing the stuff and producing results and things like that. And then, you're not the person doing the stuff anymore. You're the person that's supervising the people doing the stuff, and you're, rewarding incentive structures in your mind kind of have to get rewired and like, I mean, that's a big transition.
Yeah, you described it really well, Mike. It is a big change in just how to think, and yeah, the obligations that I have are very different, but the methods of thinking like a scientist have helped me. Um, it helps me every day in understanding, why we budget certain things certain ways and why we have to set priorities. So I guess all my experience before has helped me more than I thought that it would.
Awesome. Congratulations.
Thank you.
Does anybody have any, if you've done that transition before, right, to more of kind of a supervisory position, do you have any, I don't know, any words of wisdom for Erin, anybody?
I can go. This is Bridget from Onondaga County. I made that transition about 8 years ago, and I will say that it does get easier to do the supervisory work if that's not your background. When I came into my role, that was not my background. And I had a hard time the first year, but then after that, I think as you kind of start to do things more regularly, more frequently, you'll get a good sense of that. And I wanted to share, for me, one of the challenges has been like quality improvement, or excuse me, quality assurance of the work of my team members. And that was something that kind of caught me off guard with the supervisory piece. I thought it would be a lot of mentorship, but there was also a big part of making sure that the work that they were doing was done with sound methodology, etc. So I think having that strong epi background is really useful moving into that role.
Thank you.
Awesome. Any other thoughts or advice or words of wisdom? Has anybody else had a work transition since we were together over the summer?
So I think I
Well,
saw another one in the chat. Go ahead.
I guess I should probably let all the trainees know that I've had a work transition since we met. So when in June I was at when we met, I was an associate professor at University of Minnesota, and in August I wound up joining the faculty at University of North Carolina.
Jamie, we lost you, I think. For everyone else? Yes? Okay.
Yeah. So
Okay.
the word she was finishing was University of North Carolina. So yeah. Oh, what's that, Catherine?
Just clarifying, at Chapel Hill.
Yeah. Right. Right. Yeah. Yeah. So that's exciting. Well, maybe she'll be back. Very good. Well, yeah, I mean, I'll open it up. Anybody else, anything anybody else wants to talk about? Some people have put some of their data stuff in the chat. So if you want to talk about any of that, we can. Other topics?
I'll share just from participating in the training, it's got me thinking about like just looking out for different opportunities to get more experience in epidemiology, because the training helped me see, oh wow, like this is a pretty fun area, and I didn't realize how much I was missing from my role, or just how much I would enjoy it, because my master's is in social work and stuff, and my particular role doesn't do a lot of epi stuff because of other things. But one thing I would share is that my job is sponsoring the certificate of public health exam. And so I decided to move forward with that. So at least I can get a free certificate now and still be able to continue to look out for opportunities and whatever. So yeah.
Awesome. That's exciting. So when do you sit for that exam? Do you know?
I'm going to aim, well, we have to sit for it by June 30th. So I'm going to sit for it in June.
Very good. Have you like started preparing for it?
We actually have our first review session today after our session. So they're providing us sessions, helping us with materials, and helping us with study groups as well.
That's exciting. I mean, I don't have much experience with that public health certification exam. I know it's been around for a little while now. Has anybody else gone through that process before?
Yeah, it's difficult, but it's not overwhelmingly difficult. It's kind of maybe comparable to a graduate exam.
Yeah, I've also taken the exam. I think for people who don't have a data background, the data components are difficult, but I think since you've done this course, you'll have strength in that area. I think some of the other stuff's a little bit more common sense, just kind of best practices in public health. The one section I think I studied the most for was there was some environmental health things that I had taken the exam a while after I finished school, and I didn't use that skill set a lot. So those are a little more technical as well. But I think, like was said, I don't think the exam is particularly difficult per se if you study. Nothing really caught me off guard or anything. It's great that they're offering those resources to you.
How many people have jobs that require that? I'm just curious. Like, what are the opportunities that open as a result of having that certificate?
I got it when I was already working for the health department I work at, so I don't know that it really changed anything for me. But I do know that graduates of the university that I finished with, Upstate University, now is requiring that for students as part of their graduation. Like they need to do that to be considered having completed the MPH program. So I know locally we have a lot more people now that have it. When I did it, I don't think very many people had it, so I don't think they knew really what to make of it.
Interesting. Great, thanks. Well, good luck in preparation for it.
Yeah, and as Sarah mentioned in the chat, I know at least USF used to require it, or strongly encourage, or I don't know exactly what it was, but I'd be curious to I don't know, to hear from Bill Sappenfield about it sometime, having spent so much time at USF. Yeah. Interesting.
To get into more like data stuff, there's something that my team here is going to look into more in alignment with our strategic plan as a department, and that's maternal mortality. And I know we didn't really talk about that a lot we talked about infant mortality, obviously. And with kind of the national dialogue around maternal mortality, I'm just curious if, like, as you do the future training courses or even like the the follow-ups that we have, if that's something that we could delve into a little bit more. I have an idea of like what I'm going to do because I have access to our local vital statistics data, but it's just kind of a topic I haven't spent a lot of time with, but is obviously very important.
Richard, I'm glad you bring this up, and I'm very biased because this is the topic I work on naturally. So we have previously done a post-training webinar focused specifically around this topic. But what I'd like to hear from you is, in this topical space, what would be most helpful? Because I think we've given an overview of the topic, kind of showed national data, here's the landscape of where things are. But for where you're located and sitting and what you need to do, what would be most useful in terms of thinking about the data in particular?
I think for us, our concern is that because we have a small number of maternal deaths, which is good, obviously, it makes it difficult to look at things by like race and ethnicity, because we're particularly interested in figuring out if there's racial differences. And so like dealing with small numbers, I think, is helpful. It's something that came up when we were in the training course as well, but we didn't touch on a lot. And just kind of like a sound methodology, like the PPOR, I appreciated because it gave you kind of a sound methodology for looking at the infant side of things. If there's like things that have been done before or articles that could be shared or anything like that, might be helpful.
Are you working at all with your state maternal mortality review committee?
No, and we haven't really started, like, this is just kind of on the horizon. Right now, we haven't like started external conversations about it. I know we have within our county, we have a child fatality review. It's at the county level that we participate in. But I don't think we've had any conversations beyond like the local level.
I think
Near
doing
Onondaga
mortality-
County.
Oh, sorry, go ahead.
No, nothing, I was just clarifying, she's in.
Sorry,
Onondaga.
what?
Onondaga.
I'm from Onondaga, yeah.
How
I'm
big is
sorry,
the
I'm
county?
having a hard time hearing Catherine, but I think the question was what county I'm from, which is Onondaga County in New York State.
And how big is the county? How many births do you have, say?
We have about 5,000 births a year. And I think as a county as a whole, we have about like 3,500 deaths a year. Maybe a little bit more. Not like maternal deaths, just like deaths in general. Obviously that's maternal deaths we'd have a problem. But we haven't done a ton with our death data, just in general. We have some challenges with accessing it in a way that is set up to do analyses. It's really more of like a looking manually at each death certificate type of process. We do know we can ask the state for data sets as well, but they're usually delayed by a couple of years. So we're curious too with COVID and all of that, like how that's impacted things. So we might create a process internally using our own death certificates and work with our IT department to figure out a way to index the death certificates so they can be scanned. So relevant fields can be scanned and put into a database. We do that now for other parts of the death certificate, but not cause of death. There's a box on the death certificate about whether if it's a female, if they were pregnant, I think it's in the 35 days before. So that's something we might be able to index, but lots of conversations that need to happen to get that going.
Are any other, does anybody else work in a sub-state agency, so county or local, that have their own access to vital statistics, or are you mostly all dependent on vital statistics going through the state offices? Like, are there any good case examples of how a local agency could do that?
So at Cradle Cincinnati, we partner with our county health department to get vital statistics data. We've gotten permission from Ohio Department of Health to go directly through our county to be able to get it, to make it in a more timely manner. And so we're very fortunate that like we can run data monthly and have internal monthly meetings around like, what does our infant mortality look like? What's our race ethnicity breakdown? And so we can make more timely decisions and have conversations with our partners about the landscape and kind of what we're seeing. that partnership was kind of put in place when I was at the county health department, and a little bit before then. So it's kind of been in place for like 10-ish years. But I know it was more of like a data use agreement with our state health department of, what is it that you're trying to do and how do you plan on using it? And they've been super cooperative with us about, the work that we're trying to do and like how we're presenting it to community partners and sharing it with partners and things like that. So I literally just kind of work with our county health department, and they send me updated birth and death files on a monthly basis, and we just run some code and pull out some different things.
Here at Central Jersey Family Health Consortium, we're actually currently working with the Rutgers Integrated Population Health Data Project to look at maternal morbidity and mortality in the COVID era. And through that, they gave us the birth certificates, death certificates, as well as hospitalization files. So we've linked all three at the statewide level. So you could also reach out to see what different kind of projects are going on, and they could provide you data through that.
Thank you, that's helpful. It actually makes me think about, like, you're talking about the birth certificate data. We have access to that as well, and that's actually in a much easier to use format. So one of my thoughts was to take I can download an Excel or a CSV file of all of the deaths that have happened in the county during a time frame, and it just has the fields that are currently indexed, which would be like name and date of birth, and I think maybe address. But I can run something where I'm comparing the people who died to the people who gave birth to see if they are the same people. So that was one approach I was considering. And then if we find anybody that's a match, manually look to see cause of death, at least in the short term, until we have a better process in place. And that's probably what we'll end up doing. But it's tough because there's always spelling issues and typos and all that fun stuff that can make that challenging. But it's definitely, like, we have some good data to work with. It's just figuring out a good way to streamline it for regularly being able to access.
Do you work with SAS by any chance?
We have a SAS license, but I think that's going to go away in February. And we're going to be doing SPSS because the cost to the county is significantly less. And we don't have anything like right now written in SPSS that would help, but that's the plan.
Because I would offer, I'm not sure I'm in New Jersey, so I don't know if the birth certificate is like the same or like the data sets are similar, but I would be willing to, share code if that would have helped, but you're switching to SPSS.
Thank
Sorry.
you. I appreciate it.
And then Bridget, one other thing I thought about when I worked at the county and was the FEMR and CFR coordinator, we worked with our local hospital systems to provide us access to their Epic. So as we were doing some of the reviews, if we needed more like details on, say it was an infant that died from like a medical reason and we needed, additional things, we were able to have access to log into that hospital's Epic system and get that patient chart, which is like a very unique access that we had. And I recognize that was a huge privilege, but it was something that we were able to kind of work with them to get access to under like our Ohio revised code for CFR. Mm-hmm. And so I think as you kind of look to some of that, like that, you can look into some of your state revised code or policies and things like that to see if there's any support around some of these maternal or the mortality reviews, and see if that's an area of opportunity. And I know that really helped us when we were looking at like all the premature related deaths that we were seeing, to be able to see like what were some of the like actual causes and like what was mom experiencing that led to the premature birth. And so those have been very helpful.
Yeah. I know one of the things we talked about, we have at least at the local level, we've discussed this. We're in the process of trying to create an academic health department linkage with SUNY Upstate, which is one of our largest hospitals in the area. And Epic has been discussed as part of that. I don't know if they would allow us to access like, an individual record for that use, but that's worth thinking about for sure.
Yeah, and we have one actually, I work at Children's and they would not an Epic like portal. So we would request the record for like the specific child, and then they would pull the record and dump it into that portal. So we didn't have access to all of their Epic, but we still were able to like request specific hospital files. So there were like some ways we had to get creative to work with the hospitals on what they were willing to do, but it was super helpful in being able to see some of the like underlying causes that led to some of those.
That's really helpful. Thank you.
I'd encourage you to think too. So maternal mortality is between 15 and 40 per 100,000. And you've got, how many people did you say? How many births? 5,000?
Yeah, a little around 5,000 in the county.
Yeah, so you're talking about, such a small number that like
Right.
statistical analysis is not
Yeah.
really a thing you're doing. You're looking at cases. But
Right.
what I would consider, so it may be worth like thinking about an automated pipeline for death certificates broadly, because that could be useful for all kinds of things.
Right. Yeah. Because we were thinking about that for COVID and other stuff
Yeah,
too.
exactly right.
That we wish we'd had that when COVID happened.
But another thing to think about if you were able to work with the state to access it is if you could get hospital discharge data, you could think about something like severe maternal morbidity, which is about 50 times more prevalent than maternal mortality and is, sometimes called a maternal death near miss. So it's more prevalent and therefore, perhaps more analytically tractable and also very important. Lots of challenges in actually capturing it with administrative data and ICD codes. Like getting Epic data would be great because you can get a lot more clinical information. But anyways, that is just another strategy.
So what was it that you were calling that discharge?
Hospital discharge. So HCUP is like the national version of it, but most states have hospital discharge. I actually know New York has it because we are using a New York hospital discharge data set right now for a project on substance use and pregnancy.
Interesting.
So somebody at the state has it, and it has, I think the New York data has zip code in it, so you could get down to some kind of a sub-state level.
Okay, that's
all
really
of
helpful.
Hospitalizations, which usually includes emergency, inpatient, and maybe ambulatory. So like somebody who goes for a same day surgery kind of thing, and all of their ICD codes and race and ethnicity and age and payer and stuff like that.
Okay, that's great. Thank you.
I will share that Washington, D.C., we're at our health department, we're working on linkages because of the legislation that we have that mandates hospitals to report incidents of mortality and morbidity within 5 days. And currently that time period isn't even reached. And our system is set up to where with vital statistics or vital records data, no one else in the department has access to it unless you're an employee within that department. So we're working with our IT department to build a way where we can communicate with hospitals to bring that data to us, and then we'll do the linkage within DC Health and then be able to push that data back out to whoever needs it, as long as it's in accordance with the law. So the last meeting we talked about ADT, which is admission data transfer, something like that, that will communicate with the EHRs to our systems. And we're using a case form that will bring it all together because we already have the data for like birth, for like clinical information. We just need hospitals to kind of verify it so that way it can all come together in that one case form, and then we'll be able to see the mortality, morbidity data and just in one snapshot.
So, oh, good. Thanks, Michael. So, I mean, I think the suggestion for trying to get hospital discharge data to look at severe maternal morbidity is a good one. There's, I think, also been some work at state and federal levels, and Catherine, you may know more about this, but looking at that pregnancy checkbox on the death certificate and comparing the yield from that pregnancy checkbox and trying to identify true maternal mortality cases to the linkage of birth and death certificates to try to identify them or other methods. So, I mean, what is the level of evidence right now about the utility of that pregnancy checkbox? I don't know if Catherine, Michael, or anybody else is up on that.
There's a bunch of papers that have looked at this in different ways. It is, it's fraught. The pregnancy checkbox was supposed to be this great way to capture on death certificates the possibility that the decedent was pregnant in the previous either 42 days or a year. One thing that was apparent early on in the adoption of the checkbox was that like 60-year-old women were having the checkbox checked, like they're or 10-year-olds, and maybe possibly the 10-year-old was possible, but like there were extremes that were improbable, and in fact, a lot of times that happened. So there have been some changes. National Center for Health Statistics has changed a little bit about how they clean the incoming data to try to fix some of those things. They used to, and maybe Catherine does know more about the specifics of this, they used to do some automatic development of ICD codes, O codes, which are the obstetric codes, when the checkbox was checked, and then maybe they do that a little differently. So it is challenging, I think, using the checkbox kind of along with other information. So PMSS and the maternal mortality review committees, they usually use the checkbox as a starting point, but then also do some other linkage between vital records, between birth files and deaths. Yeah, Catherine's just pointing out there are actually sort of three main data systems in the US we have for maternal mortality. Two are federal. Well, one's generated from the state and goes up. PMSS is sort of managed at the national level, and MMRCs are state specific.
Yeah, and you'll, for many of you that are working in state and local areas, you are the ones that theoretically, or your contacts, have access to your data at that level. We federally are not able to look at state level data unless it's provided to us from the state and has permission. So the PMSS rolls up state data into national numbers. But I shared with Bridget privately, but I can put in the chat. I gave a presentation in 2020. So thanks, Ashley, for reminding me when that was on maternal mortality. A lot has changed since then, and I present on this every year, and I'm happy to share my presentation. And I get into the checkbox topic pretty carefully and thinking about how that may impact results. And I know that of those three systems that I noted there, I noted them in the order that I actually consider from weakest to strongest, to be honest with you, in terms of the information that it tells us. I think the other thing to think about too that MMRCs have been particularly important in, and that is tracking on other causes of death, and PMSS does a little bit too, that we may not get from NVSS. And those would be things like maternal mental health conditions, for example, thinking about injury and how that's incorporated. Those are areas that, the NVSS doesn't include those things. And then you start getting into pregnancy associated deaths. So those are basically in the universe of deaths that occur during pregnancy or after pregnancy, and then whittling that down to those that are considered pregnancy related deaths, those that are deemed actually related to the pregnancy itself. And so I think for us, the maternal mental health conditions is a big topic that in CDC's latest reports from MMRCs has shown that being a leading underlying cause of death. And some of these other sources wouldn't give you that level of information. And so the MMRCs really contribute data on contributors. They really dig deeper into what those contributing factors are. But I can talk about this topic all day long, but I have a presentation and I'm happy to share that, afterwards. I don't drill down necessarily to the local level, but I think, Bridget, some of the things that you're acknowledging are certainly relevant to everybody. And when thinking about small numbers, and I think for us nationally, even at the state level, I mean, we roll up multiple years of data, in our reporting, particularly for Title V. I mean, we often present a 5-year estimate for that. And especially when you start looking at stratifiers and trying to look at certain racial and ethnic populations, those numbers get a lot smaller, which is why you see, for some, you'll notice when CDC puts out their maternal mortality rate data on an annual basis. So that should be coming out. It's delayed this year, but we're anticipating that, I think, by March. And those should be 2022 mortality data. So those are the most current when they do come out. So there's a bit of a lag, even more of a lag with PMSS, because, they're linking to those birth and fetal death certificates, and that process just takes so much longer. But on the NVSS, I'll just say that they have provisional, more current data online. But just thinking about back what I was saying about certain populations, when CDC puts out their report, they only present on white, Black, and Hispanic. Okay, they don't put AIA in there. You could go to CDC Wonder and calculate these things, but one of the caveats here is just these numbers are incredibly small. And they're very important. And I know us at the Bureau, we want to show as many groups as we possibly can. There's no sugarcoating and hiding groups or anything like that. Like, we want to put out all that information. And that information can be calculated. But when you get into the race ethnicity piece, you also get into potential misclassification issues too. So it's very nuanced, but important to put as much as we can out there to highlight that the disparities are there. And not improving, unfortunately. And I hope you could all hear me. I put my video back on, but I don't know if the connection was good. Thanks, Michael.
Yes, we did. I was going to add the misclassification issue is a concern of ours as well if we were just to rely on the death certificate, because we find that often that's somebody looking at a body rather than, asking somebody. So linking that with the birth certificate might be a little bit better, depending on how those data are collected at the hospital level, but certainly something that impacts the quality.
So that issue of linking, right, death and birth certificates has come up, a couple of times, and that's not an easy thing to do necessarily. And there are several different ways that it's done. So I think it would be useful to talk about that for a minute too, right? I mean, how do you do that linkage? And then what are the best ways to do that linkage, right? Like, if you, like, even in a small area, right, you have a pretty large number of birth certificates and death certificates to link, and you expect a pretty low yield, right? Because maternal mortality is so rare. So I think somebody asked this in the chat. Oh, Aaron did too. So how do folks approach that? What are recommendations for doing that linkage? And Catherine, is there any federal recommendation for that linkage that you know of?
Not that I'm prepared to share at this moment, but it's something I can certainly follow up on.
Just broadly to sort of frame the options and just to see if any of you all are using any of these maybe in other settings too. Like record linkage usually falls into two camps. There's deterministic linkage and probabilistic. And deterministic is like doing a merge on a data set, right? You have like a social security number or the first and last name or something like that. You just like, if they exactly match, then they link. And if they don't exactly match, then they don't. You can imagine like a million ways where they don't exactly match, right? Even if it's real. But the probabilistic linkage is another method, which is kind of allows for a little fudge room, right? Like the date of birth matches, except, you know, instead of 13, it was 31. So it like maybe says that's a plausible kind of error to make a digit transposition. So there's software to do both kinds. And I'm curious, just having said that little bit, deterministic and probabilistic, if anybody in their jobs now is using either of those kinds of approaches for any kind of data linkage, not necessarily this specific example we're talking about.
Yes, so we have linked birth and death certificates, and we've done it. We had de-identified person ID numbers, and so we linked. So if there was a person ID number with a birth and the same person ID number came up in the death, then we linked those together.
Yeah,
So
so
do you
that's
know
an example of deterministic, I think. Sorry, go ahead.
Do you know how those individual ID numbers are created? Because I've seen that done multiple ways too, and that could, I mean, that could feed into some of those like misidentifications. Right, a match should be made, but it's not quite, or maybe it shouldn't and it is, depending on the way that ID number is calculated.
I'm not actually too sure. I would think it might be based on medical record number, but we just got the data set from Rutgers University. So I'm
Mhm.
not too sure how they came up with how to make that person ID.
Just as an
I
example. Oh, go
Oh,
ahead.
sorry. I was just gonna say that we've used a combination of both approaches in the past for different projects. We always start with the deterministic approach, and then we don't have the software to do it. So we, depending on the size of the data set, may approach a hand done process. We wouldn't probably do that with a file that large with the births and deaths, but we've done it with linking other records, as you mentioned. I think for us, likely we would, if we're linking births and deaths, we would likely use the name and date of birth and we sometimes create a unique identifier that's like the last 4 digits of the person's name and their full date of birth, and see how many come out as a match, and then kind of go from there. We usually just do that in Excel, and like sometimes we play around with like, maybe we should do more characters, like the last 6, but some names are shorter or whatever. We've done that recently with our lead data, trying to identify which clients were served in prior years. I came to find out after doing all that there was like a patient ID number that was in the system that could have been used, but we learned a lot through that process, and just kind of like seeing what are common ways that things can get messed up, to help identify how to like build that into our process.
There are so many ways it can get messed up. Using medical record numbers is challenging if you're doing anything outside of a single health system, because there's no rule that one health system uses the same medical record number as another. It's not even guaranteed that if you come back to the same place, they will, although they obviously try to.
Yeah, we saw that a lot during COVID because we were looking up individual records, and there would be, someone would have like 3 records where their first name was spelled wrong in one, and then the test result would go to one record, but then the treatment details were in the other. And I'm sure the person serving the patient in front of them knew all the details, but for us on the back end, it's like, okay, what's going on here?
So I guess that's a good question for me to ask is we've done this linkage and it seemed to work, but I mean, I could always dive deeper, and if there's anything that would stick out to you as these aren't a good match, like something that that if you ran like a frequency analysis or something that you'd kind of question like, oh, is this a true match?
Age is pretty reliably recorded in almost every data set. And so if you had a big age discrepancy, like you totally could have a 1 year if one record was before their birthday and another was after their birthday. But if you have a decade discrepancy or something like that, that would be weird. Race we talked about could be misclassified. So it could be that it really is the same person and it's marked different, but it also, if race is discrepant, that might be an indicator. It's hard to know. If gender was discrepant, you'd wonder, there's lots of reasons why gender could be discrepant. So some of the things that feel like we're probably pretty good at recording, checking a frequency if you have those variables measured in both is good. There are, sometimes people will have sort of a small subset of their data where maybe they've got the gold standard and they actually can evaluate how well their linkage method works against the gold standard, like calculate sensitivity and specificity. So Georgia, for example, uses a deterministic linkage across all vital records. And we were able to calculate using a probabilistic process, which we thought was more accurate, that it was sensitive. In other words, when it made a link, we thought it was real, but it was not very specific, which is to say that a bunch of real links got missed. So just knowing that helps you kind of think like, what kind of ways could I be wrong when I use these data?
That's extremely helpful because that's something that, we didn't necessarily dive deep into yet. So definitely having that advice is great. Thank you.
So in terms of linkage methods, I've also seen methods where it's what I would consider kind of between deterministic and probabilistic linkage, right? Like you do say you have say you have 4 identifiers, right? You have first name, last name, date of birth, and social security number. And if they match on all 4 of those, then you feel really good about the linkage and you don't look at those again, right? So that's the deterministic part. And then if they match on 3 of them and 2 of them are date of birth and social security number, you feel really good about those too. And then if it matches on 3 of them, but either the social or the birthday doesn't match, right? Then those are like reviewed one by one, right, by a person. And then if they match on just 2, then we maybe don't consider those linkages or whatever. So I've seen processes like that include deterministic and then some criteria for inspection, right? Like, putting eyes on it. So it's not like usually a probabilistic linkage kind of gives you a percentage or a score or something like that for how confident you are in the match. And like those software programs, like there are some that are that you pay for and some that are available for free, and they can use things like Soundex codes and things like that. So, if a name like Sean can be spelled multiple different ways, and if it's spelled one way, that's really different in one data set than another, but they sound the same, then it'll give them a higher probability linkage kind of thing. So those things sometimes get into probabilistic linkage, but like I said, I've seen some processes that I think of as not probabilistic because they're not doing things like that. They're not assigning an accuracy score or something like that, but they're not exactly deterministic purely too, right? They're kind of a combination of deterministic and individual review that like don't really take specialized software, but might take a little bit more time.
I wanted to add too, for us, one thing we see a lot of, because we have a large new American population, is people who maybe aren't familiar with names and they don't know what's a first name versus a last name. That's often flipped. So sometimes it's simple as like trying it the other way. That happens with our lead testing data a lot, because there's regulations for refugee families to be tested up to age 16 in New York State. So a lot of our cases of elevated lead are in that population. So it's just something to think about. Might be as simple as flipping the name around.
And sometimes hyphenated names are,
Yeah, those can be
are really tricky too.
real tough.
Yeah.
We had a lot of trouble in COVID times with that.
In the tool that the method that the Georgia Department of Public Health uses, this deterministic linkage that I said, when we did our validation study on it, the group that it performed most poorly for was Hispanic women, and we think it was about having multiple names that might be recorded as a surname. So basically, that issue of which name gets put in the last name column.
And also even names like O'Connor that have like an apostrophe.
An apostrophe, sure.
Some programs don't like realize that that's an apostrophe or whatever. And some people leave it out when they're typing a name into a system and others don't.
Very good. Are there other issues around linkages that people want to share or have questions about or thoughts about? All right, what about the maternal mortality and severe maternal morbidity data? We've been talking about this for a little while, and I think it's been great and interesting. I mean, has it been helpful, Bridget and others who are dealing with these data and these issues?
Definitely. I think there's a lot that was in the chat that I think will be really useful, particularly the ICD code thing for the severe maternal morbidity. Especially like that can be a way to approach the small numbers issue. And I never would have thought of that. Thank you.
Good. What else folks want to talk about? Anything going on? All right, well, we're at the top of the hour, so if there's nothing else that folks want to talk about, we can just wrap it up here. All right, Ashley, I think that we have another webinar that's on a focus topic, right? Not just kind of
Yes, in 2
Right,
weeks we'll be
so-
with Bill on needs assessment and probable identification, and that's part 2 that we usually try to incorporate into on-site, but we weren't able to this year. So Bill's going to join us, and I know it's timely for many of us. So yes, in 2 weeks, same time on a Thursday. So yeah, if this is a natural stopping place, I will be sure to share the recording and then everything captured in the meeting chat as well, and try and organize that so it's digestible for everyone. So that'll come your way.
Very good. All
Thank
right,
you for
well, thank
spending
you
an hour
everyone for your
with us.
time. Yeah.
Thank you.
Great to see you all.
Thank you.
Thank you.